Hi everyone, hope you're all doing good. We are going to discuss about endocrinology in pregnancy. Okay. So, what we are going to basically discuss is the various hormones, okay, their actions, and what is the role of corpus luteum, what is the role of placenta, what is the part of fetus itself in maintaining the hormonal levels, and then we are also going to discuss about the changes in the endocrine organs. In the mother. Okay, so these are the things we are going to discuss about. Now first I'll start from basics. Okay, so we all know, imagine this is the uterus, okay, and the fallopian tubes with the fimbria, and imagine that there is ovary. Okay, now what is going to happen? So in ovary there is folliculogenesis, right? So folliculogenesis is going to take place, and at a stage, okay, ovulation is also going to happen. Okay, so the ova is released. Okay, so this leftover cells in the tertiary follicle or the Graafian follicle, which consists of theca cells and the granulosa cells, right? So this is made up of theca cells and granulosa cells. Okay, so the leftover cells of tertiary follicle, namely the theca cells and granulosa cells, are now going to form the corpus luteum. Okay, now after ovulation, the ova is picked up by the fimbria, okay, and this is going to travel. Say somewhere in the ampulla of the fallopian tube, okay, if it is going to meet a sperm, then there is fertilization is going to occur. Okay, then this fertilized zygote is going to travel, and at a state of 16 cell, it is called as morula. Okay, now this morula is a highly impacted consists of highly impacted cells, and when there is fluid accumulation inside the morula, okay, this will be split up into a layer of inner cell mass and a layer of outer cell mass. Okay, so this structure is known as, yes, very good, it is blastocyst. Okay, and in the blastocyst we have cells. Okay, so one is inner cell mass, and the outer layer of cells is the outer cell mass, is also known as the trophoblast. Okay, now each cell of this blastocyst is called a blastomere. Okay, remember, blastomere is a totipotent cell. What is totipotency? Totipotency is nothing but at this stage each cell, each blastomere is capable of becoming a complete individual embryo. Understood? Okay. Now what I am up to say is, we are going to discuss about the hormonal action, right? So after this, it is the trophoblast differentiate into outer layer of syncytial trophoblast, inner layer of cytotrophoblast, and imagine this is the embryo. Okay, So what is going to happen is, from this syncytial trophoblast, okay, so this is the syncytial trophoblast and this is the cytotrophoblast. From syncytial trophoblast, there is a hormone going to be produced. That hormone is, yes, very good, it is HCG, that is human chorionic gonadotropin. Okay, remember this HCG will be produced even from 8 days after fertilization. Okay, so this is what is going to happen. Okay, now if you see the corpus luteum, okay, corpus luteum has two fates. Okay, it has two fates. Number one, okay, what if the fertilization occurs? And number two, what if the fertilization does not occur? Okay, so in the corpus luteum, if the fertilization occurs or not, okay, even before that, okay, corpus luteum starts secreting progesterone, okay, and this progesterone hormone is going to prepare the endometrium for implantation. So even before implantation itself, this is going to be produced. Okay, and suppose if the fertilization occurs, okay, and as we have seen, fertilization occurs and finally blastocyst is formed and then it is getting differentiated into syncytial trophoblast and the cytotrophoblast and HCG is produced, right. Now this HCG is going to support this progesterone hormone. HCG is going to support the progesterone hormone by helping the corpus luteum to secrete more progesterone. Okay. In other words, HCG is a luteotrophic hormone. Okay. So it helps corpus luteum to secrete hormones, not only progesterone, also the other hormones secreted by corpus luteum also. And if you see, so I said corpus luteum is going to be supported by HCG. What is corpus luteum going to do? It is going to produce progesterone. Okay, it is going to produce progesterone which is going to cause relaxation of the uterus and it is making the endometrium ready for the blastocyst to implant, right. So finally, it is the embryo itself, okay, that is bringing out all the changes and it is going to help in carrying out its own growth and pregnancy. Understood? Okay. Now, so this is what is going to happen if fertilization occurs. Suppose if fertilization does not occur, what will happen? The corpus luteum okay, will go for degeneration and it will become, yes, it is known as corpus albicans, which is a greyish white scar-like tissue. Understood? So, we can also call this corpus luteum that is favoring the fertilization as corpus luteum of pregnancy or corpus gravidatus. Okay, just like how we called the corpus albicans here. Understood? I hope this part is clear. Now, we'll see what are the hormones produced by corpus luteum. If you take corpus luteum, it mainly produces progesterone, then estrogen, especially the estradiol form, which is E2. Then it also produces inhibin and relaxin. Understood? Now, if we take the progesterone hormone, we already saw this is going to be produced by corpus luteum, and at one stage placenta is going to be formed, and this placenta is going to take over the function of corpus luteum. Okay? So, what is going to happen is corpus luteum produces progesterone till 7 weeks of gestational age properly, and placenta is going to take over control. This is very important, takes over control between 10 to 12 weeks of gestational age. Okay? And this intermittent period, okay, between the change is known as luteal placental shift. Okay? So, there is overlapping of the production of hormones by both the corpus luteum and the placenta, and this can happen between 6 to 9 weeks of gestational age. So, remember here, even from 8 weeks of gestational age properly the placenta starts production, but it completely takes over its role between 10 to 12 weeks of gestational age. I hope you got the point, right? Okay. Now, we will see about placenta. Regarding the hormonal role of placenta, placenta is an incomplete endocrine organ. Okay? It is not capable of independent steroidogenesis. Okay? So, basically the fetus and the placenta are going to function together as a single unit. Okay? And this unit is called as feto-placental unit. You got my point, right? Now, we will see this feto-placental unit. First, we will take the mother, then we will take the placenta, then we will take the fetus. Okay? So, this unit and this cycle is very important to you to understand the further coming sessions also. Okay? So, what is going to happen in the mother is, we have cholesterol. Okay? This cholesterol is converted into pregnenolone, and this pregnenolone is acted upon by 17 alpha hydroxylase to get converted into diaz, that is dehydroepiandrosterone sulfate. Okay? Now, in placenta also, the cholesterol is going to get converted into pregnenolone, and some of the cholesterol from the mother as well as the pregnenolone from the mother is also going to pass into the placenta, and this is going to be acted upon by 3-beta hydroxysteroid dehydrogenase. Okay, and it is going to convert it into the hormone progesterone. Okay, now what is going to happen is this diaz, that is dehydroepiandrosterone sulfate, is going to travel into the placenta and it will be converted into the various forms of estrogen, namely estradiol and estrone, which is E2 and E1, and this again will travel into the maternal bloodstream. Understood? Now the same way, what is going to happen in the fetus? In fetus, the pregnenolone is going to come here, okay, and pregnenolone sulfate is going to be formed. This is converted into 17-hydroxypregnenolone sulfate, okay, and that is converted into dehydroepiandrosterone sulfate. Okay. Now after this conversion, this dihydroepiandrosterone sulfate, okay, some of this hormone in the fetal liver, okay, is going to converted into 16-hydroxydihydroepiandrosterone sulfate, okay, and again what is going to happen is this is going to travel into the placenta where it is going to converted into 16-hydroxyandrostenedione. After this conversion, this will be converted into one of the most important forms of estrogen. So tell me what it is? Yes, it is estriol. Okay, estriol is nothing but E3. Okay, now this E3 is going to travel into the maternal blood. Okay, can you see what has happened? So all these systems are working together, okay, to produce these various hormones. I'll complete another part also, like what is going to happen to the progesterone. Progesterone is also going to travel into the fetal system and it will be acted upon by the enzyme 17-alpha hydroxylase, okay, where this will be converted into 17-hydroxyprogesterone, and this progesterone is now going to be converted into androgens, and androgens will be acted upon by what enzyme again? Any guesses? Yes, it is aromatase enzyme, and this will be converted into estrogens again, which will be again entering the maternal blood system. Understood? Also, remember the fact that progesterone and 17-hydroxyprogesterone both are going to be acted by one common enzyme, that is 21-hydroxylase, and they are going to be converted into corticosteroids. Okay, corticosteroids, namely it is cortisol and aldosterol. Okay, I hope you got the point. Okay, now once again we'll see this in this picture. I know this will be difficult for you to understand, so we'll repeat it once again with this schematic diagram so that it will be easy for you. Okay, so basically there are three compartments we are going to consider. Okay, one is the maternal compartment, another is the placental compartment, another is the fetal compartment. From the maternal compartment, cholesterol is being converted into pregnenolone, and this pregnenolone is acted upon by the enzyme 17-hydroxylase, and this is converted into dehydroepiandrosterone sulfate. Okay. Now, in the placenta also, this cholesterol is converted into pregnenolone and progesterone. The enzyme active here is 3-beta hydroxysteroid dehydrogenase. Okay. Now, this dehydroepiandrosterone sulfate is going to enter into the placental system, where this is converted into the estrogen forms, namely estrone, which is E1, and estradiol, which is E2. And this is again entering into the maternal blood system. Okay. Now, in the fetal, this point I forgot to tell you, that is in the fetus, especially the fetal adrenal glands are important. Okay. So, the fetal adrenal glands are going to receive this pregnenolone from the placenta, and this is going to get converted into pregnenolone sulfate, which is further converted into 17-hydroxypregnenolone sulfate, which is converted into dihydroepiandrosterone sulfate, and some of the dihydroepiandrosterone sulfate is converted into 16-hydroxydihydroepiandrosterone sulfate, especially in the fetal liver, and this is going to enter into the placenta, where it is converted into 16-hydroxyandrostenedione, and this 16-hydroxyandrostenedione is going to get converted into one of the most important forms of estrogen in pregnancy, that is estriol, and estriol is entering into the maternal bloodstream. Understood? Okay. So, all these things you have to know, and also how the progesterone is converted. Now, from this fetoplacental unit, okay, what are the conclusions we can derive? Okay. So, remember, estrogen, we saw 3 forms of estrogen, right? It is E1, E2 and E3. Okay. And among these, E3 is coming from where? E3 action, this production of E3 is being started from the fetus. Am I right? So, since the production is starting from the fetus, this E3, which is a specific form of estrogen in pregnancy. Estrogen in pregnancy is also can be taken as a marker of fetal well-being, right? So, if there are adequate amounts of E3 is produced, then the fetus is also normal. The functions, the enzymatic activities, the steroidogenesis in the fetus is going to happen normally. This we can understand, right? So, that is point 1. Okay. Point 2, what I wanted to tell you is, even then, all the 3 types of estrogen are produced, okay, but as seen in the reproductive phase of life, estradiol is going to be the most abundant form of estrogen found in pregnancy. Okay. So, there is nothing to get confused. Once again, I will tell you. So, if you take the estrogen hormones, so first one, it is going to be estradiol. Okay. Okay. Then it is going to be estriol. Then it is going to be estrone. So, if you take the various estrogen forms, the most abundant form in pregnancy is going to be estradiol, followed by estriol, and followed by estrone. Understood? So, for the conclusion, this is going to be the most common or most abundant form of estrogen, and estriol is the most specific form of estrogen in pregnancy. Understood? Yes. And the second point or second conclusion what I can derive is, placenta lacks the enzyme 17-hydroxylase. Okay. And the third conclusion what we can arrive is, fetus lacks the enzyme 3-beta hydroxysteroid dehydrogenase. Understood? So, since placenta is lacking one enzyme and the fetus is lacking another enzyme of steroidogenesis, these are going to together act as a unit and it is going to produce all the steroid hormones, namely estrogen, progesterone and even the androgens, corticosteroids, etc. Understood? And one more point I want you to tell is, we are all aware that there is amenorrhea in pregnancy. Okay? If you ask me, ma'am, why there is amenorrhea in pregnancy? How does it happen? Why there is no menstruation happening during pregnancy? Okay? So, from the corpus luteum itself, we have seen the estrogen, progesterone, inhibin A, it is A form, and relaxin are produced. Okay. Now, the first three hormones are going to act upon this gonadal axis. Okay. And it is going to inhibit the gonadotropins, namely the follicle stimulating hormone and the luteinizing hormone. Okay. And it suppresses the ovary. Ovary is suppressed. So, no ovulation, okay, and no menstruation, okay, and this leads to amenorrhea. Understood? Okay. Now, we will see hormones one by one. Okay. First hormone is progesterone. We know this is a steroid hormone. Yes. And initially it is produced by corpus luteum. Then it is going to be produced in more amounts by placenta. Yes. Now, what are the functions of progesterone? Functions include, number 1, it prepares the endometrium for implantation. Number 2, this brings about decidualization of the endometrium. Decidualization means the endometrium of uterus is going to split into 3 layers, namely decidua, basalis, decidua capsularis and decidua parietalis. Third point, this is going to bring, next function, this brings about uterine relaxation in pregnancy. Okay. So, that is why the hormone progesterone is very important, okay, for maintaining the pregnancy in early stages as well as the advanced stages, okay. And even before delivery, what is going to happen is, there is going to be progesterone withdrawal, okay. So, at that time only the labor is going to commence. Understood? So, suppose if the progesterone level is going to reduce in the early stages of pregnancy, then it can result in abortion. or miscarriage. Okay. Suppose the level of progesterone is getting reduced during any time before 37 weeks. Okay, before 37 weeks. Then it will result in uterine contractions because the relaxation is not going to be there. So, uterine contractions will occur, okay, and that can give rise to preterm labor, okay. So, in both these cases, we can manage by giving progesterone supplement. Okay. Next one, this is going to affect the cyclical gonadal axis, the fertilization and conception, everything. But there is preservation of gonadal function. Okay. And next one, it is going to inhibit the T cell activity. So, the immunosuppressive effect is brought about. So, the concept is not treated as a antigen. Okay. And next important thing is, this is also going to antagonize the effect of angiotensin. Okay. Now, basically from the name itself you would have got angiotensin hormone means it is going to constrict the blood vessels. Okay. So, this is basically going to produce vasoconstriction. Okay. But progesterone is going to oppose this action and it is going to bring vasodilation. Okay. So, because of this vasodilation that is by progesterone, there is going to be warmth and low BP that is felt by the mother during pregnancy. Understood? Estrogen generally is seen in 4 forms: E1, E2, E3 and E4. This is estrone, which is the predominant form of estrogen in menopause. And estradiol is going to be the predominant form of estrogen in reproductive life of women. And E3 is the specific estrogen to pregnancy. This is also going to be produced in pregnancy, E4. Okay. Now, if we see exactly how estrogen is formed from the fetoplacental unit, we have seen that it forms from the fetal adrenal glands, especially the E3 and E4. So, this is basically not seen till 9 weeks. Okay. That means that is the time when the fetal adrenal glands become matured. Yes? Okay. Now, what are the functions of estrogen? It is responsible for bringing maternal adaptations in pregnancy. Okay, the various adaptations in pregnancy in the mother is brought about by the hormone estrogen along with progesterone hormone. Okay. it is going to cause breast growth and development. So, in the breast, we can consider two parts, namely the ducts and the alveoli. Okay. So, the growth of the ducts depends upon the estrogen hormone, and the alveoli growth is brought about by both the hormones estrogen and progesterone. Okay. And then estrogen is also going to bring about uterine growth. We know the uterine growth in pregnancy happens more by hyperplasia than hypertrophy. Okay. And also it brings about the oxytocin receptors, okay, in myometrium. So, especially before labor, if we see, okay, what is going to happen is the first hormone going to increase is the estrogen hormone, and this is going to increase the number of oxytocin receptors, okay, in the myometrium. Then oxytocin hormone is going to act via these receptors and uterine contraction is brought about, which is helpful in expelling the fetus. Understood? Okay. Now, we will see the other two hormones produced by corpus luteum. Relaxin. So, as the name suggests, okay, this hormone is going to relax the joints, namely pubic symphysis and sacroiliac joints. Okay. Then this is going to bring about changes in the reproductive organs also. Okay, especially it causes, yes, again it relaxes the myometrium of uterus and it also causes cervical ripening. Okay. And remember, relaxin is not only produced by corpus luteum, it is also produced by the decidua and placenta. And one more point in the function of relaxin is it causes vasodilation also, okay, where this brings about increased renal blood flow and this leads to increased glomerular filtration rate. Understood? Next hormone is inhibin. Okay. So, this hormone is also produced by placenta. Inhibin hormone basically going to antagonize the actions of the hormone activin and it is going to inhibit the production of gonadotropin releasing hormone, especially from the placenta. And there are two forms of inhibin, say inhibin A and inhibin B. Okay. So, inhibin A is what is produced by the corpus luteum, and if you see the function of inhibin B, this is going to give a negative feedback on follicle stimulating hormone. And inhibin A is used as a marker in Down syndrome where the levels are going to be reduced. At the same time, suppose if the levels are increased, then this is going to denote abnormal placentation. Okay. So, it is used as a marker in cases of preeclampsia, fetal growth restriction, etc.